Hello everyone, I am Michele Farcisco. I am currently a researcher at the Center for Research Ethics and Bioethics of Uppsala University, as well as in Biogen, which is a genetic research institute in Italy. I'm very happy to participate to the World Coma Day, and I thank all the organizers for this opportunity to present a recent research that I have coordinated as part of my research activity in philosophy and ethics with a specific focus on disorders of consciousness. Today, I will talk about an international survey on the implementation of the European and the American guidelines on disorders of consciousness. So we recently published a paper about this, starting from the two guidelines, which are currently the most updated guidelines about the clinical care provided to patients with disorders of consciousness, specifically the European one, and this is the paper where these guidelines have been presented. So the European guidelines have been issued by the European Academy of Neurology, and also the American guidelines, which have been presented in this paper. And these guidelines are from the American Academy of Neurology, together with the American Congress of Rehabilitation Medicine and the National Institute on Disability, Independent Living, and Rehabilitation Research. This is the paper where we presented the result of this survey, an international survey that I coordinated as part of my collaboration with the International Brain Injury Association, specifically with the special interest group on disorders of consciousness. The paper has been published in the journal Neurology in 2023. So we elaborated together with people from this interest group, we elaborated a questionnaire in 2021, and the questionnaire was conceived in order to explore the opinions of professionals working with patients with prolonged disorders of consciousness about selected recommendations from the two guidelines. We also added some further questions related to the impact of COVID-19 pandemics on the clinical care provided to these patients. And so we have been discussing the draft of this questionnaire over a period of 1 year. And so the process has been quite long in order to agree on the final version of the questionnaire. And the survey was launched in February 2022. We organized the questionnaire around 7 topics with different number of questions. The first topic, of course, was about the demographic of the participants, then another about diagnosis, then families counseling, prognosis and rehabilitation, pain, collaborations, and nosology. The sections were included on the basis of what was in the guidelines. So the guidelines were the reference to elaborate the questionnaire. In this slide, you can see a summary of the demographic of participants. So female participants are slightly more than the male participants. We have respondents from all around the world, mainly physicians, and specifically working in intensive specialized rehabilitation units. And the majority had more than 10 years of experience. Here you have a summary of the main answers that we collected. I just want to stress some of them. The first about the diagnosis. The first question was whether clinicians, the professionals participating in the survey usually try to prime the patient's arousal level before assessing their level of consciousness. And this is a recommendation, an explicit recommendation of the guidelines. And the majority of professionals is consistent with this recommendation. Importantly, they say that it is possible in their center to integrate expert clinical evaluation, EEG-based technique, and functional neuroimaging for the evaluation of patients with disorders of consciousness. This is a crucial, a central recommendation of both the guidelines to provide a multimodal assessment of consciousness in these patients. It seems that it is possible, even though a number of difficulties emerged, and I will focus on them in the end. Importantly, the pandemics, the COVID-19 pandemics, resulted to have an impact on the way they assess consciousness, but not so much impact. More or less half of the participants declared that the pandemics impacted on the way they assess consciousness. Very importantly, the vast majority of responses declare to involve families in the diagnosis and also in the rehabilitation program of the patients. Specifically to the question, do you or your team provide evidence-based prognosis information to family members of patients with disorders of consciousness? 92% of participants said yes. And this is very important, as well as also another question, do you or your team inform families about the limitation of existing evidence concerning currently employed treatment and related potential risk? 99% of participants declared yes. This is an important point because there is so much, or still so much uncertainty in the diagnosis of these patients, and it is crucial to involve families in this kind of discussion. In the discussion, I mean about the limitation of the present diagnostic tools, as well, of course, about the potentiality of these tools. So, in short, it resulted that families are quite involved in this kind of discussion, and this is very important. Concerning the rehabilitation program, the vast majority declared to update the rehabilitation program regularly on the basis of repeated assessment of consciousness. This is also an important recommendation from both the guidelines to provide a rehabilitation program which should be updated on the basis of the repeated assessment of residual consciousness. Pain is an important topic. And the majority declare to assess pain specifically in patients with disorders of consciousness, even in the case they are unsure about the patient's level of consciousness based on the bedside assessment. So besides the level of uncertainty about the level of consciousness, the vast majority of professionals assess pain. Not only they assess pain, but they also think that pain should be treated regardless of the level of residual consciousness. This seems consistent with a precautionary approach. And it is also an important point because there is still discussion about how to specifically handle possible pain experience in these patients. Because, for instance, if you provide too much analgesics, you may risk to further reduce the residual level of consciousness in these patients. So in the end, you can increase the risk of misdiagnosing these patients. So it's important to find kind of balance between the need to avoid painful experience in these patients and to, of course, maximize the chance for a good diagnosis, for a true diagnosis of these patients. Another important point is about the collaboration, because both the guidelines specifically recommend to collaborate with other center, and the majority of responses, 72%, declare to work collaboratively with other centers or other experts in disorders of consciousness. And this is so consistent with the guidelines. Finally, about the nosology, the classification, the definition of disorders of consciousness, the American guidelines specifically recommend to replace the term vegetative state with or unresponsive wakefulness syndrome with BUS, UWS, and the specific duration. So to add the specific duration of the impairment. And 73% of participants declare to agree with this recommendation. This is important because there is still discussion around how to classify these patients. I mentioned that even though the majority declare that a multimodal assessment of residual consciousness is actually possible in their center, they also mentioned a number of difficulties, and among them, the most important is the collaboration by the patient, followed by a logistics problem, let's say issues, as well as neurosurgical issues, cost, and medical stability of the patients. So here you have an illustration of what should be considered in order to further improve the implementation of a multimodal assessment of residual consciousness in these patients in order to be compliant with the recommendation by both the guidelines. So in this kind of summary slide, we can see the most and the least implemented recommendations as resulting from the survey that we have been conducted. Concerning the diagnosis, the most implemented recommendations are increasing arousal before assessing residual consciousness, also using coma recovery scale revise for the behavioral assessment, and also observing spontaneous motor behavior before assessing consciousness. So professionals declare to do this in accordance with the guidelines, while the least implemented recommendations are repeating clinical assessment of consciousness. An important point is that there is no consistency among the respondents about the modality and the frequency of repeating this assessment. So this is a point to work on. Also, integrating bedside behavioral examination with technological assessment is not so much implemented. So it seems that there is a lack on this point, as well as implementing multimodal diagnostic assessment. So this is something to still work on. Concerning the prognosis, providing evidence-based prognosis information to family members, as I mentioned, this is a point this is a point that the majority of professionals declare to be consistent with, as well as with counseling families, identify patients and their families' preferences, inform families about the limitation of actual diagnostic, prognostic, and therapeutic approaches. Concerning pain, the majority declare to specifically assess it and also to counsel family members about the difficulty to assess pain. It's not so implemented, the recommendation to use the nociceptive coma scale revised. And so this is recommended by the European guidelines, by the way, and it seems that there is not so much agreement and consistency by professionals on this point. The majority declare to collaborate with other centers, and so they are consistent with this recommendation. And also, they agree to replace the term permanent or chronic vegetative state or unresponsive wakefulness syndrome with BUS, UWS, and the specific duration. So this is also implemented by the majority of respondents. So here you have a kind of summary of the most and least implemented recommendation, which is indicative of the present way to do in the clinics and can also indicate where to further focus in order to improve the actual situation. We also included an ethical analysis of these results, and here you see the main ethical challenges that resulted from the survey. First, the limited implementation of multimodal diagnosis, and there are different reasons for that: lack of technology, lack of skilled personnel, prohibitive cost, among other things. The point here is that we need to identify clearly who is responsible for what in order to minimize the negative impact of all these factors. So we need to be clear at which level try to assess and fix these issues. If, for instance, at the level of management or scientific direction, rather than the level of the individual clinician work. So it's important to advance in this more granular analysis of who is responsible for what. Another important and ethically relevant point is pain, both detection, which is of course something to invest in, and treatment of pain. The treatment of pain, as I mentioned, is not so easy to assess from an ethical point of view, because you need to avoid the risk of impacting some capacity which are ethically relevant, like autonomy and self-determination, for instance, using disproportionate analgesic treatment. So it's important here to advance in the clinical assessment of pain, and also, of course, in the scientific research that can help clinicians to have a clearer picture whether the patient is actually experiencing pain or not. And a last point, which is connected specifically to COVID-19 pandemics, is safeguarding a sufficient involvement of patients' representatives despite the restrictions imposed by COVID-19 pandemics or other kind of pandemics. I mean, we can generalize here, because as I mentioned, the majority of respondents declared to take care of families, we may say, so to involve families. But of course, the pandemics impacted negatively on this involvement, so it's important to anticipate possible, further pandemics, and so to think about how to keep family involved despite possible similar events. So to conclude, some final suggestions and future perspectives. We recommend in our paper to elaborate a strategy for assessing the main factors that limit the integration of clinical evaluation, EEG-based technique, and or functional neuroimaging. Specifically, we identified as problems in this regard: lack of technology, lack of expert skilled personnel, and high cost. And we suggest that maybe the creation or the enhancement of specialized hubs of disorders of consciousness expertise at both national and international levels may be a fruitful strategy to implement in order to improve the multimodal diagnosis of residual consciousness. Another point is about elaborating a strategy for improving a multimodal diagnostic approach, particularly the use of neurotechnology, elaborating clear and consistent recommendation about when to use it. And also a promising model in this respect is a structured approach to disorders of consciousness at the national level, possibly complementing it with relevant international collaborations. So to enhance national organization, but then also try to implement important, relevant international connections. Another recommendation is to develop a more robust evidence-based recommendation on the frequency of the assessment of consciousness to better standardize clinical practice, because there is very much disagreement on the frequency of this of the frequency of repeating the assessment of consciousness. And for instance, a possibility may be to use a simplified behavioral assessment. Also, we recommend to identify the underlying causes of the lack of specific and multidisciplinary rehabilitation programs and elaborating concrete strategy and action plans in order to improve the care of patients of the care of patients with disorders of consciousness, not only in intensive rehabilitation unit. And also elaborating, and this is again very important, clear and specific recommendation about the detection of pain and also the treatment of pain, and also negative discomforting experiences in general, in order to minimize any possible risk of side effects impacting the level of residual awareness. So this survey has been an example of how the clinical treatment, the clinical care of patients of disorders of consciousness, even though has been improved also internationally with important guidelines, still needs, of course, specific assessment, not only from a clinical point of view, but also from an ethical point of view. There are plenty of ethical issues that should be considered and analyzed in order to eventually provide the best possible care to these patients. Last point is, of course, about the COVID-19 pandemics or other possible kind of pandemics, and so try to anticipate the potential negative impact of these events. That's it. The very last point, how to promote a better in-person or remote interaction between the patients' families and clinicians and patients and their families. Because again, the professional declared to involve families, to take care of families, so we should try to further enhance this involvement of the families. Let's say I thank you all for your attention, and I thank again the organizer for having invited me. Thank you.